Hi everyone, thanks for listening to my presentations. Today I'll be talking about N-Acetylcysteine. This is a strong antidote and a mucolytic agent. Sit back and let's go. N-Acetylcysteine could be known as Antidote, Cetilef, or Parvoles. Those are brand names depending on your jurisdiction. And it belongs to the class of antidotes and a mucolytic agent. Uses as an antidote in the face of acetaminophen overdose or acetaminophen toxicity or poisoning. N-acetylcysteine is the drug of choice. As mucolytic agent, very useful in respiratory system, particularly in the face of chronic emphysema, cystic fibrosis, atelectasis due to mucous obstruction, post-traumatic chest conditions, and diagnostic bronchial studies. Like the name depicts, mucolytic, it breaks down the mucus. That is why people with cystic fibrosis will benefit here, or there's collapse of the lungs secondary to mucous obstruction. In respiratory system, as a mucolytic agent, we use N-acetylcysteine emphysema with bronchitis. We also use it in tuberculosis, bronchiectasis, in amyloidosis affecting the lungs, in pneumonia, in tracheobronchitis, and tracheostomy care, so as to break down the mucus, and of course during anesthesia. In acetaminophen toxicity or overdose or poisoning, we'll be making use of Rumack-Matthew Nomogram. But before I'll continue further, I need to clear this. Someone whispered to me that you're talking about acetaminophen, that some people will not even understand what they're talking about. You better go by the brand or trade name. Oh, sorry about that. Tylenol or Paracetamol. So either we have known that the individual has ingested Tylenol or Paracetamol, or that is what we're suspecting. In either case, once the case is pointing to that, then we'll have to commence N-acetylcysteine within the first 8 hours. Before the commencement of N-acetylcysteine in the face of Tylenol or Paracetamol toxicity, overdosage, or poisoning, we have to do some tests, liver function test, liver enzymes, before, during, and after the treatment. And of course, we cannot be running a blind procedure. We have to assay for the level of acetaminophen in the serum. Still, with acetaminophen toxicity or overdosage, we will have physical examination for features of acetaminophen toxicity, because that will be very helpful. We have to determine the chosen route. For example, we can give an acetylcysteine per oral or intravenously. If we choose the per oral route, we administer the medication for 72 hours. So it's going to be 72 hours treatment. So we will admit the patient, and we'll be standing with the patient with nurses all around for 72 hours, doing everything, investigation and everything. If we choose the intravenous route, it will be 21 hours treatment. You may extend the treatment hours if there is need for that. But please discuss with your team and determine that liver pathology is actually present. The value of acetaminophen in the serum should be assayed, not just a guesswork. Massive or large dose of the acetaminophen or Tylenol or paracetamol will determine the extension. Other medications ingested concomitantly will also determine that. Persistently elevated acetaminophen level will determine extension of treatment beyond the 72 hours or 21 hours. And of course, increased INR or unfavorable continuous elevated liver function test or liver enzymes results will give us the clue that, oh boy, this is not good. Don't stop N-Acetylcysteine right now. More treatment is required when we go through all this. Okay, you can give activated charcoal within the first 2 hours. Okay, then we will contact the poison center. The full course of therapy is 18-dose course of therapy. If we are choosing the oral route, that is, the patient is not vomiting, then it means we are going for a 72-hour regimen. Within the 72 hours, we will administer 18 doses, given as follows. The loading dose will be 140 milligrams per kilogram. After that, we'll be giving 70 milligrams per kilogram every 4 hours, times 18. If we have chosen the intravenous route, it means we are going to give it by infusion, and that will take 21 hours. We'll give 3 doses, given as follows. The loading dose will be 150 milligrams per kilogram over 1 hour. After that, we'll give 50 milligrams per kilogram over the next 4 hours. After that, we'll then give 100 milligrams per kilogram spread over 16 hours, making 21-hour regimen. Note, we have to discuss with pharmacists, toxicologists, and other physicians around about the need to reduce the volume in people with less weight. Anyone less than 40 kg cannot take the same dose that we're going to give everybody above 40 kg. Some may use 2 bags instead of 3 bags that I've stated above. 2 bags is given as 2 doses, given as 200 milligrams per kilogram over 4 hours, then 100 milligrams per kilogram over 16 hours. Some will use 1 bag or single bag method. A bag given as 1 dose with 150 milligrams per kilogram over 1 hour, then you adjust it to 40 milligrams per kilogram per hour for the next 20 hours. The dose will vary with weight. As a matter of fact, we are going to do a lot of mathematical calculations here, okay? You may require consultation with expert to administer the following within 72 hours. If you are given per oral for 72 hours, the loading dose might be 15 grams, while the maintenance will be at 7.5 grams every 4 hours. If you are using the intravenous route, that is 21 hours, you can give the loading dose at 15 gram infusion over 1 hour, and second dose at 5 gram infusion over 4 hours, the third dose at 10 gram infusion over 16 hours. In respiratory system, you can administer nebulized bronchodilator 10 to 15 minutes before the administration of N-Acetylcysteine. Let me repeat. For cystic fibrosis, and you want to give N-Acetylcysteine for mucolytic purposes, then you have to administer the bronchodilator ahead about 10 to 15 minutes before administering N-Acetylcysteine. We can give this through inhalation, nebulization, per face mask, or tracheostomy, or through mouthpiece. The dose is essentially that N-Acetylcysteine 10% plus 20% sodium chloride or sterile water can be given 2 to 4 times per day. You can instill 1 to 2 ml of 10% solution into tracheostomy. You can use percutaneous intratracheal catheter 1 to 2 ml of 20% solution every 4 hours. in pediatrics. You can use the per-oral route for 72-hour regimen or use the intravenous 21-hour regimen. In repeated supratherapeutic ingestion of Tylenol or Paracetamol, you can start treatment immediately. All other factors as in adults are applicable here. In respiratory disorders, you can give aerosolized bronchodilator 10 to 15 minutes before N-Acetylcysteine nebulized inhalation. Remember, I said that as per the adult also, okay? You can use face mask, mouthpiece, and tracheostomy, just like in adult. In infants, you can give 1 to 2 ml of 20% solution 3 times or 4 times daily. In children, you can give 3 to 5 ml of 20% solution and maybe further diluted with sodium chloride or sterile water for inhalation. Or you give 6 ml to 10 ml of 10% solution undiluted 3 times or 4 times daily. In adolescents, you can give 3 to 5 ml of 20% solution as above, or you have what is called tent or croupe, where you're going to have 10% or 20% solution and you're going to individualize that. Endotracheally, you can administer 1 to 2 ml of 10% to 20% solution every 1 to 4 hours as may be required. Percutaneous endotracheal catheter could take 1 to 2 ml of 20% solution or 2 to 4 ml of 10% solution every 1 to 4 hours. In respiratory disorders of gastrointestinal tract, for bronchogram, neb or endotrachea. Rectal enema, if you are dealing with meconium myelus or distal intestinal obstruction syndrome. The dose forms are here. I will just pause to look at it and confirm that with a pharmacist to determine the route you're going to use and be able to give appropriate dose. So inhalation, intravenous Antidote, intravenous generic. Tablet effervescent. N-Acetylcysteine is incompatible with certain medications. Tetracycline, erythromycin, trypsin, halogen peroxide, amphotericin B, iodized oil. No N-Acetylcysteine with them. Adverse reactions: autoimmune, anaphylactoid hypersensitivity or bronchospasm, increased heart rate, nausea and vomiting, pharyngitis, rhinorrhea, bronchitis or throat tightness, rash. Contraindications: only hypersensitivity to acetylcysteine or any of its component formulation. One, there is that possibility of fatal anaphylactic reactions that may occur, but it may also resolve spontaneously. Therefore, slow administration will be very helpful. And if you notice that we're going to give intravenously for over 21 hours and per oral for over 72 hours, you'll see why it's like that. Still part of warning is we're going to watch against fluid overload. Okay? So we check for sodium level because there's likelihood of hyponatremia. And with that, there will be cerebral edema leading to seizures and probability of death. We have to adjust volume based on all associated factors and check periodically while slowly administering the medication. Be careful. In asthmatic patients or anyone with history of bronchospasm. No need of Rumack-Matthew Nomogram in the face of repeated supratherapeutic ingestion. So don't waste your time about that, okay? Determine the hepatic injury with history, the dosage of the Tylenol or Paracetamol or Acetaminophen ingested, the liver enzymes results, and of course the clinical state of the patient. Because we're not going to treat the lab, we're going to treat human beings. The lab reports will only guide us. Monitoring. Am I dealing with any anaphylaxis? What is serum acetaminophen giving me right now? Any AST, ALT, any bilirubin, PT or INR? What is the APTT telling me? How about the glucose level, creatinine, blood urea nitrogen? And of course, the report from the nurses and what I could examine as per the clinical state of this affected individual. And with this, I've come to the end of this very presentation. Please remember to subscribe. I appreciate it. Also remember to share. Thank you.